morning, ladies and gentlemen. My name is Nirav Shah, and I am the director of the State of Maine's Center for Disease Control and Prevention. We again begin today's briefing on a somber note. Maine CDC is aware of 2 additional deaths among individuals who had been diagnosed with COVID-19. One was a gentleman in his 80s from Cumberland County, and the other is a woman in her 90s from Waldo County. All of us here at Maine CDC and across the state government of Maine extend our deepest condolences to the families of all of those who have been affected by COVID-19, and in particular, the latest 2 individuals who have passed away. I'd like to next provide an update on the number of cases and other numbers of COVID-19 statistics across the state. As of this morning, Maine CDC is reporting 560 cases of COVID-19 across the state, an increase of 23 cases since yesterday. We're also aware of at least 105 hospitalizations among individuals who have been diagnosed with COVID-19. Sadly, as I mentioned a moment ago, there have also been 16 deaths among people who have been diagnosed as well. All told, 202 individuals have recovered from COVID-19, which represents an increase of 15 since yesterday. Since beginning its activation, Maine CDC epidemiologists have fielded now 4,530 consults, questions and inquiries from members of the healthcare community across the state. In addition, there have been 11,608 individuals in Maine who have tested negative for COVID-19 and the coronavirus that causes it. I'd also like to provide a quick update on the composition of some of the cases in Maine, particularly with respect to Maine residents who might be living in another state, as well as residents of other states who might be currently residing in Maine. As of yesterday evening, there are 13 Maine residents who have tested positive for COVID-19 in another state. They are included on our list of confirmed cases. In addition, there are 17 individuals whose address of permanent residence is in another state who have also tested positive in Maine. Again, there are 13 Maine residents who may have tested positive in another state, and there are 17 individuals who are residents of other states who may have tested positive in Maine. I'd like to take a moment to discuss a particular healthcare facility that is of the top priority and top concern of the entire team that is working on COVID-19 right now. And that is the Tall Pines facility in Waldo County. At present, Maine CDC is aware of 10 residents of that facility who have tested positive, as well as 3 staff members who have tested positive. I want to take a moment and pause on the residents who may be living at Tall Pines right now, as well as individuals who may be hospitalized with COVID-19 or have ever been hospitalized. When I think about that, I think about right now what it means to be hospitalized or to live in a long-term care facility in this time of COVID-19. And I just want all of us to bear in mind the challenging conditions that hospitalized individuals and those living in long-term care facilities are facing. In many instances, all visitation has been restricted. In some cases, even movement within the facility has been restricted in order to minimize the chance of spreading the virus. These are, for all of us, difficult times, but for those who are hospitalized or who call their home a long-term care facility, it is especially difficult. Folks who are in the hospital may not have friends and family who can come visit. The same is said of long-term care. The gift shop might not be open. It may be difficult to even get on the phone with somebody. And so we, all of us at Maine CDC, just want to keep those who are hospitalized and those who are living in long-term care facilities right now at the top of our minds. Maine CDC staff have been working with the Tall Pines facility since first learning of an uptick in the number of cases. Maine CDC's emergency preparedness team shipped Tall Pines an order of PPE on Monday of this week. As we've learned more about the evolution of the number of cases there, our infection control team has been on the phone with Tall Pines, giving them guidance on how to keep residents safe. Our emergency preparedness team is continuing to work to supply the facility with additional PPE, and our team of epidemiologists is working with the facility to try to get a handle on who's infected, who's at risk, and who should be tested. Right now, this is one of our top priorities across Maine CDC, across the entire team that is working on the COVID-19 response. And we wish everyone at the Tall Pines facility nothing but the best. And we will continue to stand by you throughout this. I'd like to next provide an update on laboratory testing. And I'll start with respect to a set of rapid diagnostic test machines that are from Abbott. Not long ago, I reported that Maine CDC had been informed by the United States federal government that we would be receiving an order of a cache of 15 Abbott testing machines and approximately 2,300 tests. This is a device that can test for COVID-19 very quickly. And as we've talked about, our strategy in utilizing this device was twofold. The first was as an effort to reduce the amount of PPE that is needed before someone gets a positive or negative test, because a lot of PPE is used while healthcare providers are awaiting a test result. The second strategy we discussed is using these machines in order to get a rapid result on individuals we believe could be lost to follow-up very quickly. For example, individuals experiencing homelessness. We were initially told by the federal government that we would receive approximately 100 kits. Each kit can do 24 tests. And so we were informed that we would have an initial testing capacity of approximately 2,400 tests. We learned over the weekend that we would in fact still be receiving the same number of machines, but rather than receiving 2,400 tests, we would only be receiving 120. That presented a challenge for us, and as I mentioned yesterday, we went back to the drawing board. Now, I want to be really clear. The information that we have been receiving and the contact that we have had has been via the U.S. federal government. Yesterday evening, I spoke with a senior executive at Abbott to make sure I understood what was going on and open up a line of direct communication with that company. And this gentleman informed me that although the initial number of tests that we received was not what we were told by the federal government, additional tests might be on the way. And so in response to that, I asked the team at Maine CDC to immediately put in an order for additional tests, which we have done. Right now, we're evaluating what our strategy for these 115 or 120 tests that we have, what our strategy will be for those. There are a number of different options on the table. And making a decision for such a small number of tests and such a high amount of demand is very challenging, and I acknowledge that. Right now, one of our top strategies will be to ensure that individuals who are at a high risk for being lost to follow-up, for example, again, those who might be homeless, trying to make sure we can get a rapid result back to those folks as quickly as possible so appropriate public health and social services interventions can be provided as quickly as we can. I'll have more to come on that strategy once we've worked it out and once we know exactly how best to use this very valuable resource at this time. I'm also able to report that we have had very productive talks with a primary care clinic group here in Maine, Martins Point Healthcare, about the possibility of sharing some of their test kits with the state of Maine. The talks have been extremely collaborative and productive, and I'd like to commend and thank our colleagues at Martins Point for the discussions we've had so far. I'll have more to report on those discussions tomorrow, but for right now, I would really like to extend a thanks to the team at Martins Point Healthcare for the very productive, collaborative discussions that we've had. We're really thankful for their partnership, and I hope that I'll have much more to report tomorrow. I'd also like to thank Abbott as well for these devices, as well as for the test kit supplies that we've already received. We look forward to working with both entities going forward. I'd like to turn next to some additional numbers around what we've seen with respect to transportation into Maine. As we've talked about, one of the keys to flattening the curve is reducing the amount of physical contact. This is consistent with Governor Mills's executive orders to limit entry and to limit movement so that we can disrupt the natural flow of the virus. We recently spoke with our colleagues at the Maine Department of Transportation, and they report seeing significant reductions in traffic along the roadways in Maine, specifically on the interstates, and even more specifically in urban areas. If we take a look at the traffic patterns from this past week and compare them against the traffic patterns from exactly 1 year ago, what we see are significant reductions. For example, on I-95 in Kittery at the Maine-New Hampshire state line, there has been a 61% reduction in traffic flow. In Portland, on I-295, right near the Fore River Parkway, there's similarly been a 62% reduction in traffic flows. Overall, across the state, traffic patterns on the interstates are down approximately 53%. There's also been a significant reduction in traffic along rural highways, but more on the lines of 30 to 40%. This is in keeping with the thanks that I offered to everyone in Maine yesterday for reducing their travel and introducing as much physical distancing as possible. These latest statistics from the Department of Transportation are proof positive that when Maine people are asked to stay in for the common and for the public good, they do so. And we thank again everyone in Maine for continuing to abide Governor Mills's executive orders and stay inside. Right now, staying inside and introducing physical distance is the best vaccine that we've got. I'd like to turn next to an update on our activities along the public health emergency preparedness front. Today and tomorrow, there are 90 orders that are going out from healthcare institutions across the state, fulfilling their requests for different types of PPE. We also received a notification from the US CDC that they would be shipping to us an additional 15,000 surgical gowns, as well as an additional 16,000 gloves in the coming day or two. We continue to look for additional sources of PPE across the state, not just from the federal government, but also from other private market suppliers, as well as trying to produce or continuing to produce PPE here in Maine for Maine healthcare workers. And again, we'll have additional updates on that as we go along. I'd like to finally conclude with providing a brief update on the number of vital assets that we track across the state. At present, there are a total of 308 intensive care unit beds across the state, 149 of which are available. There are also 333 ventilators across the state, 283 of which are available. There are also 232 of these alternative ventilators. All told, this means that our total ventilator capacity across the state of Maine is 565 ventilators, and of those, approximately 515 are available. I'd like to pause now and turn things over to our colleagues in the media for questions. And so we will start today's questions with Paul Dwyer from WABI.
Good morning, Dr. Shah. Thanks for taking the question. Can you talk about just any data that you have from looking at other places with similar geography to Maine, that with Maine's spread out population, we could see we could be less prone to a huge spike in cases like we've seen with more densely populated areas, but potentially more prone to a longer drawn out spread, and then how we would be able to deal with that over like a longer period of time.
Great. So Paul raises two really great points. The one is how does Maine currently stack up against some of our cohort states? And then what might the implications of that be for the length of any outbreak? And so, Paul, I'll give you a couple of pieces of data. The first is that we often look to see how things are going in New Hampshire from an epidemiological perspective. I checked this morning, and New Hampshire is reporting over 700 cases, close to 800 cases, whereas we are at about 560 cases. New Hampshire is also reporting, I believe, 18 deaths, and while we are at 16. So New Hampshire appears to have a higher number of deaths, but roughly the same number of individuals who have passed. We've also taken a look at where Maine stands with respect to our overall testing numbers per capita. We'll get you those exact numbers, but the last time we ran the numbers, which was yesterday evening, Maine was the 13th highest state in testing per capita, number of tests done as a function of our overall population. Now, your question also asks, to what extent might there be implications of this for the duration of an outbreak? And Paul, again, it's a great question, but it's difficult to speculate. On one hand, areas that have more spread out geographies have less transmission, and so that's a good thing. On the other hand, those areas may also have less access to health care. What that means to us is that we need to make sure that health equity remains top of mind for us, and make sure that health equity remains the lens through which we look at this outbreak, and making sure that individuals who live in rural parts of the state have access to testing, have access to EMS transport, and have access to sophisticated health care so they can get the care they need. So happy to provide you more of those numbers, Paul, with respect to where Maine stacks up in terms of testing, especially testing per capita. I'd like to turn next to Caitlin Andrews over at the BDN. Caitlin, go ahead, please.
Hi, thank you, Dr. Shah. I'm glad you brought up social distancing and my hometown, New Hampshire, because that's what my questions kind of have to deal with. So you mentioned that it seems like social distancing is down. Have you figured out how these new infections are occurring as other parts of the state have been closed, a lot of public facing things, but cases continue to rise? What kind of environments are these infections occurring in?
Great. So Caitlin, one minor but important point. Our data show that physical distancing is up, not down. Just wanted to, I know that's what you meant, but I just wanted to make sure I was on the record with that. Our data do show, both from traffic as well as from cell phone data, that physical distancing is up. There's more distance between one another, and that's a good thing. So then the question is, where are these infections coming from? And there's two observations to make, Caitlin. The first is that before the time between when someone is exposed to the virus and that number, if that person gets sick, that number appears on the Maine CDC website, can be over 3 weeks. The reason is that it can take up to 2 weeks alone for someone to be exposed before they start showing symptoms. Most people don't immediately go to the doctor the minute they start showing symptoms. Most folks wait a couple of days, especially if it's hard to get in to see the doctor. And then even once they've gotten into the doctor, getting tested and then getting a result back can also take an additional 48 hours or so. And so thus there can be up to a 3-week time in any state, not just Maine. This is really a function of all outbreaks between someone, when someone is exposed and when the public health system finds out about it. So many of the cases that we are continuing to see, Caitlin, are individuals who may have been exposed 2 to 3 weeks ago, if not longer. However, we also know that one of the other areas in which there can be a lot of transmission based on data from other states is not so much in the general public, but within households. Household transmission in some other jurisdictions accounts for a really high percentage of new cases. Even here in Maine, what we've seen are a significant number of what we call nodes, where one person in a household may get an infection, and then we very quickly see other people within that household get that same infection. That's why one of the first pieces of advice we give to anybody, one of the first questions we ask is, who else lives in your household? And then secondly, to what extent can any one individual isolate themselves within the household to prevent that spread within that node? So those are really the two reasons why I think we're continuing to see cases. One is that we're picking up cases from several weeks ago. And then the second is that we know that household transmission is definitely a phenomenon. I would like to turn next to Steve Betts at the Courier-Gazette.
Wait, I'm sorry, Dr. Shah. I had one more quick follow-up, if that's okay.
Go ahead, Caitlin, sure.
Yeah, so you mentioned 18 deaths in New Hampshire, and according to some reporting out there, 10 of those have occurred in either nursing homes or long-care facilities. You mentioned that Tall Pines is a place that is of concern for you, and that early on in the outbreak, Ocean View also had several cases. I know you guys have kind of been holding off on saying exactly where deaths are occurring, depending on, the need for privacy and, kind of like doing that as see fits. But can you give us a sense of how many of these cases in general are happening at long-term care facilities, and whether you think that it's going to get worse at those facilities?
Great. So Caitlin is asking about the overall number of cases in congregate living facilities. And as of right now, Caitlin, there are 43 of our 560 cases in congregate living facilities. That includes not just long-term care, but group homes, shelters for people experiencing homelessness, etc. We'll get you the exact number of individuals at long-term care facilities. But overall, for congregate living, which as a group are one of our highest areas of concern, the number for all of those cases is 43. And as you correctly noted, Caitlin, that has been based on early data and experience we saw in Washington State. Congregate living facilities are one of our highest areas of concern. You asked a question about whether it will get worse. And as you know, I can't speculate. But what we have seen in other states is that congregate living facilities are a significant area of concern. That really is why our team at Maine CDC, as soon as we get wind of something happening of this nature, we're immediately on the phone with them. It's also why, even going well back before we even had a single case of COVID-19 in Maine, we were holding webinars for long-term care facilities to help them get prepared for these exact scenarios. It's impossible to speculate on what direction we may go, but I won't be surprised if we continue to see additional cases here, and they remain one of our top areas of concern. I'd like to turn things over next to Steve Betts at the Courier-Gazette.
Thank you, Dr. Shah. We know that there have been many people who have not been able to be tested because there's not enough testing materials. So how will you know when the cases are dropped enough to allow the emergency orders to be lifted and people can resume their lives as before.
Great. So Steve asks about testing and how testing might relate to removal or a return to normalcy. And Steve, let me say right up at the top that there is no backlog of any test at the Maine CDC laboratory right now. Tests come in, they're processed usually the same day, depending on what time they are received, and results are reported out to healthcare providers as soon as the results are ready. So there is no backlog of testing right now at the Maine CDC laboratory. When folks need to be tested according to their healthcare provider, our lab is standing ready to run those. But you raised the question of what does this mean for any type of return to normalcy? And Steve, I think the answer there is less about when we might return to normalcy and more about how we might think about how to make that decision. And there are many different types of factors that we will are looking at as we make those decisions. One of which is a prolonged period of time during which there are no cases. How long that time period is yet to be determined based on what we know about the disease and how we interact with other states. But certainly one of those criteria will be a prolonged period of time with no cases. It also is predicated on making sure that there is sufficient testing available so that if folks have symptoms, they're able to get tested. And again, as of right now, there is no testing backlog at the Maine CDC laboratory. I would like to turn next to Kara DeRose at the Maine Beacon.
Hi there, thank you. I guess my question is, so the most recent number I've seen is that 97 healthcare workers have tested positive for COVID-19 in Maine, so about accounting for 18% of known cases in Maine, but I'm assuming that's not accurate anymore. So has that number increased, and do we know how does that rate compare to other states and their healthcare workers?
So Kara's question is about the number of healthcare workers who have tested positive. The number currently stands at 97. We are, of course, continuing to work with healthcare facilities so that if additional healthcare workers are detected as being positive, we can work with the facility to track patients they encountered with, had an encounter with. But Kara, you also ask about how that compares against other states. There's not really a state-by-state database yet, and I don't really know to what extent other states are tracking healthcare worker exposures. We certainly are in Maine, given the number of healthcare facilities, as well as our older than average population. I can't speak for what other states are tracking, but I can also tell you that there was a study that came out of Italy during when Italy was having its significant spike. And the Italian researchers found that, as in Maine, approximately 20% of cases in Italy were in individuals who were affiliated with healthcare workers, who were themselves healthcare workers or affiliated with healthcare workers. So our numbers here in Maine largely track, at least the data that I'm aware of from Italy. There's also additional data from China, but I don't know, I'm not sure how we stack up against that, because the way the Chinese researchers categorized healthcare worker is different from the way that we do. But again, I can't speak for whether other states are even tracking healthcare workers. We certainly do in Maine, because that's a number that we're deeply concerned about. I'd like to turn next to Amy Brown at WERU.
Thank you, Dr. Shah. You mentioned some numbers earlier, and something went wrong on the call, and we didn't actually all hear them on the call, about the number of residents from out of state who tested positive who were in Maine. So I wanted to ask if you could repeat that number, and then also, that's some information that you hadn't been reporting in the past. Is that something that you'll be reporting now, and how is that being tracked?
Okay, so to go back to the numbers, Amy asked to repeat the numbers of Maine residents who are diagnosed in other states and vice versa. And as of last night, there have been 13 Maine residents, 13, who tested positive for COVID-19 in another state. And those cases are being counted here in Maine in our reporting. In addition, there are 17 individuals from other states who have tested positive in Maine. Those numbers are being recorded by their home state of residence. Amy, we haven't quite decided to what extent we'll be reporting these numbers. We wanted to just get a glance at it as we are undertaking our modeling and making sure that we're accounting for all different potential sources of infection. So I don't know to what extent we will continue to report these. We certainly, every number and every data request has to have an epidemiologist run that and verify the accuracy of the numbers. We wanted to report it today because we've gotten some more clarity on the former number, the number of Maine residents who have been tested in other states. Again, that's 13. So we've had additional clarity around that number and feel better about the accuracy of it. And that's really why we've reported it today.
17 people out of state who tested positive while they were here in Maine, not 17 people who tested positive elsewhere and then came to Maine, correct?
That is correct. While they were here in Maine, we do not know whether any of those 17 individuals is still in Maine. And we certainly don't know how many of those individuals may, for example, be a New Hampshire resident who happened to go, to a facility, et cetera. So it's the number of individuals from other states who tested positive, and they may have returned to their home state now. It's their home state that would be doing the tracking on those individuals in the same way that we are doing the tracking on the 13 individuals who were tested in other states.
Thank you.
You're welcome. I'd like to turn next to Joe Lawler at the Press Herald.
Yes, hi. Thanks for taking the questions today. So one thing I was wondering about, I know you were talking about, you're saying there's not a backlog of testing right now. So does our testing capacity, how does it compare right now to, say, 2-3 weeks ago? Has our capacity improved? And does that mean like the categories of people who are being tested has changed, has loosened up a little bit? And then just a quick follow-up on, tourist season is coming up, and I know there's restrictions on hotels and lodging and, cruise ships and all that right now, but do you think that will be extended through May and even into June possibly to restrict the number of people congregating?
Sure thing, Joe. So Joe's first question is about testing capacity at our state laboratory here in Augusta. And as of right now, we have the capacity to do approximately 3,000 to 3,500 tests. And we are continuing to work 7 days a week at the laboratory to run tests. The availability of some of the chemicals, the reagents that we've talked about, the availability of those reagents has improved. And that's a good thing compared to where we were, say, about 3 weeks ago. And so that's a positive step. We are evaluating to what extent that will change our focus areas. As of right now, we are still running a high number of tests. And so our focus areas do continue to be individuals who are hospitalized, healthcare workers, and those who live in congregate settings. The reason for that is that our turnaround time is lower than that of most all of the commercial laboratories. We're able to turn around a result at least within 24 hours at maximum from receipt, as compared to the commercial laboratories, which we understand are taking several days. And so, Joe, we're evaluating to what extent we will change our testing algorithm. Right now, our algorithm is actually more progressive, more expansive than that of the federal government's. We've done that because we wanted to include congregate settings in our top tier based on some data, ironically enough, from the federal government, from the US CDC. So right now, our testing guidelines are more expansive and more allowable than what the federal government has. That is, again, to say we focus on individuals who are hospitalized, individuals who are healthcare workers, those who live in congregate settings, folks for whom a rapid result is needed as quickly as possible. We might liberalize them even more, But again, I just want to make sure everyone's aware that we're starting at a baseline that's even more expansive than the federal government. We're also anticipating, based on what we've seen in other states, that there will be a continued high demand for testing. So we've got to make sure we're looking ahead into the future as well. Joe, your second question was around tourist season and what that might look like. And candidly there, Joe, it's impossible to speculate. We certainly hope that there is some degree of tourist season, but again, hope is not a strategy. And so in addition to hoping for the best, we're also planning for scenarios in which that's not the case. As you noted, Joe, or as it's important to remind everybody, Governor Mills's executive order remains in force, which is to say individuals who are entering Maine from any other area where there is a high degree of transmission are required to self-quarantine for 14 days in order to observe for symptoms. How long that extends, that's under discussion. So we're very well aware of that, but right now we really can't speculate on what the future will hold with any kind of outbreak. We're focused on on making sure we're taking care of people right now. I'd like to turn next to Samantha Hogan over at Pine Tree Watch. Samantha Hogan from Pine Tree Watch, your line is open.
I have two questions that I was hoping that you would address separately. First, the 13th death was a woman in her 80s from Waldo, and the 16th death that you just reported today was a woman in her 90s also from Waldo. Were they both residents at Tall Pines, and are you counting them within the 10 positives at that facility?
Samantha's question is about individuals who have passed and where they live. Consistent with our prior practice and consistent with the practice in other states, we're not revealing any information about where any particular case, positive or someone who passed away, lives, really in order to protect their privacy and the privacy of their families. So Samantha, I can't say anything more about where they may have lived.
Okay. And then I also was hoping that you would discuss or give us an update on what's going on at the Department of Corrections. They do continue to test people, and they're putting people into isolation, which generally means that they've had some level of exposure. So could you provide us an update on that?
Sure. So as of this morning, there are a total of 16 cases, 16 individuals at the Department of Corrections who have been tested. 15 of those 16 tests have come back as negative. One is still pending. I would refer further questions to the Department of Corrections. I do know that they have a dashboard that is updated at least every day, if not more, that lists further information about where folks have been tested and what the results are. But the latest information that I have from our colleagues there are that a total of 16 individuals have been tested. One test is pending. The other 15 have been negative, which means there are no positive cases of any client within the Department of Corrections. And I do want to take one more moment to express my thanks to our colleagues at Corrections. They have been at the table with us from day one, planning for these scenarios, and have made sure that they are as steeped in infection control practices as they can be. We have worked with them really, again, since day one to plan for these types of scenarios, and I commend them for their advanced thinking and asking to be at the table with us. I'd like to turn next to Steve Missler from Maine Public.
Thank you, Dr. Shah. I appreciate it. Thank you for providing some of this information about people who are out of state and in state and et cetera. I've been wondering, though, and I think I've bugged you about this before, about contact tracing. We're starting to see reports from, granted, these are major metropolitan areas where they've been able to trace an outbreak all the way back to, say, in Chicago, a funeral and a family gathering, or in New York, to a traveler from Europe. Do we have that kind of capacity here? And if so, when do you expect to maybe be able to tell us how the outbreak may have began here?
Steve, it's a great question, Steve. Steve asks about contact tracing and to what extent we've been able to trace back some of our cases to events that may have occurred elsewhere in the country and things of that nature. And Steve, the answer is we have been able to do a very robust amount of that. So much so that it's almost on a daily basis too overwhelming for these briefings to go into. But I'll first extend my thanks to our gumshoe epidemiologists. They have been the quiet heroes of this entire outbreak. Since day one, they have been out there talking to people to learn their stories, put together these really complicated timelines, and try to get a better sense of who might have infected whom. And as a result, we actually have been able to paint two very interesting pictures of the way that the outbreak in Maine has unfolded. The first is, I want to go back to, I think, what Caitlin and I talked about, which is one of the pictures that has emerged is that there's a high degree of intra-household transmission in Maine and in other states. And we've seen that repeat itself over and over again. So much so that, as I mentioned, when we get a new case, one of the first things we ask is, tell us everything about where you live, who lives with you, is there anyone elderly there, is there anyone with lung disease, because we know that the risk of transmission within households is very high, and we've seen that replicate itself. The other interesting phenomenon that we have uncovered, I want to share this in a way to make sure that we don't breach any confidentiality, but the way that our epidemiologists put this together is nothing short of astounding and awe-inspiring. Earlier on in the outbreak, we detected a cluster of cases that were linked to an individual whose job is to be a traveling salesperson. And this traveling salesperson visited a particular establishment in Maine and had a series of meetings and infected a certain number of individuals, all of whom we traced and gave advice to. But when we looked back at this particular individual's travel history, we also learned that this individual, because of the nature of their job, and notice I'm not using any gender pronouns, because of the nature of their job, had visited other similar establishments in other states. And we reached out to those states, and it turns out that this individual seems to have had a pattern of spreading COVID-19 across a number of states. And we've pieced that together. We've talked about writing that up for one of the CDC journals as an example of the work that gumshoe epidemiologists can do when contact tracing is made a priority, as we've done so here. Difficult thing for me to convey in a soundbite, Steve, so I won't go into it too much more, but suffice it to say that our team has been able to trace a fair number of the cases in Maine, if not back to sort of patient zero, but pretty far back down the line based on travel and such things. Now, when you get into a world of community transmission in Cumberland and York, that becomes very, very difficult by definition. But in areas where there's no community transmission, that's what our epidemiology team has been able to do. That was a really long answer. I hope you can make some sense of that. So I'm going to turn next to Kate Koff at the Ellsworth American.
Thanks, Dr. Shah. So the Maine Health Data Organization tracks the cost of procedures around the state, and they list them on CompareMaine.org. I know it's probably far too early to do that for coronavirus hospitalizations, but I'm wondering if you can give us any idea of what it costs to treat someone hospitalized for coronavirus, and whether you have any idea of the proportion of patients who have been hospitalized who are uninsured.
Kate asks two great questions around the cost of coronavirus care. And Kate, you're right. There have been some initial estimates nationwide of the cost of coronavirus care, and I don't have any of the main specific numbers. But one of the interesting findings from some of the analysis nationwide has been that the cost of care for coronavirus patients, whether they are in a regular hospital bed or an ICU bed, can be quite high, partly because of the high demands for PPE. PPE is not inexpensive, and because of the number of healthcare providers on a team who are required, whether that is respiratory therapists, physician's assistants, et cetera, there's a lot of PPE demands that differentiate coronavirus cases from other individuals who might normally need to be hospitalized. So it's an area that once more data are in, we'll have a better sense of here in Maine. But I know that there are models out there that have been looked at in other states to start tracking those. As to your second question, I don't have those data right now, but we'll see what we can do to find them. I'd like to turn next to Brad Rogers at WGME.
Hi, doctor. A quick question here. We are getting a lot of calls from people who say they have COVID-19 symptoms, went to their doctor, but are being turned down for testing. When will we see more widespread testing? And I think we kind of sort of touched on this before about loosening the restrictions on doctors.
Right. So, no, I want to be, again, really clear, Brad. The fundamental question of whether to test a patient is the doctor's decision. Maine CDC has guidelines, and those guidelines are actually more expansive, more permissive, much bigger of a tent than even what the federal government recommends. So what I can tell you there again as well is that there's no testing backlog at the Maine CDC laboratory as well. So we recognize that many clinicians out there, on the advice of the US CDC, as well as other healthcare institutions and other large health departments, for example, the New York City Department of Public Health, has advised physicians for patients who come to them with symptoms and who are not critically ill, not to test for those folks. We haven't made that official guidance. We still leave that discretion up to physicians. But I think it's important to note that other health departments, as well as the CDC, as well as other medical organizations, have issued that guidance. But the ultimate decision to test ultimately is up to the physician in Maine. No one at Maine CDC stands in between a physician and the way that he or she would wish us to offer a test to any patient. I'd like to turn next to Megan at WMTW.
Hi, Dr. Shah. Thank you for taking my question. It revolves around these remote care facilities or the modules. I know yesterday you were talking about working on staffing. I was wondering if you had come up with any kind of staffing plan yet and where those stand.
So Megan is asking about the staffing for the alternative care sites. One in Portland of 100 beds, the other in Bangor of 50 beds. Staff across Maine state government have been working in partnership with county officials, local officials, and most importantly, our colleagues in the hospital system to start working on staffing plans. We've gotten general agreement on how those might be staffed and what the concept of operations for them might be. For example, for the Portland facility, the patients that we're looking at for that facility would be those who are recovering from COVID-19, who are well enough that they don't need to be in a hospital bed, but are not yet well enough that they can be at home. And so the facility in Portland, once it's fully operational, the idea there is that it will be designed to relieve pressure on the large hospital systems in the city of Portland to allow them to turn around hospital beds and make them more available for acutely ill patients and allow patients who are on the upswing, who are recovering, to be in a still monitored facility at one of these alternative care sites. The staffing plan is being done in partnership with the hospitals, and we've had a really great series of conversations about who would be staffing, the volume that would be needed, and when we might be wanting to activate everything. So we're going to be continuing to work on that planning, and Megan, I'll have more information for you once we've got more granular details on the staffing. And the last question today goes to Mr. Don Kerrigan from News Center. Don, please go ahead.
Good morning. Thank you, Dr. Shah. Two questions. The first is, has Maine been asked or offered to lend ventilators to any other state, New York or someplace? Does that come up? And the second question is different in relation to the discussion yesterday about when things might get back to normal. A doctor told me this morning he doesn't think we're ever going to really get back to normal, that this virus is going to be with us for a very long time, and it's going to be affecting how we live and go about our lives for a very long time. And I'd ask you to comment on that.
Sure. So as to the former question, Don, I'm not aware of any official ask from any other state for any ventilators. And so I'm trying to think if it's come across my desk, and now I've not been made aware of any official request from any other state or any jurisdiction for any ventilator supply. As to the second question, and it's a great place to end today, Don, you ask about when we might return to normal and whether we will ever return to normal. And here's my message. There will be ways in which the way that we go about living our lives going forward will never be the same as before. I think we will now, all of us, have a finer sense for how ways that we are all interconnected across the globe can affect us. How something that starts with a few cases in a market in a town in Western China can radically affect the way that we live our lives here. And I think in that respect, we will never return to normal because we will now always have that awareness of how interconnected our world really is. And in that respect, not returning to normal is a good thing. I also think we'll have a finer appreciation for what public health does. In a sense, public health for decades has done what it does silently. We've been like this invisible force field. And only in times of stress or emergency does the amazing work that public health professionals across the state, across the country, the work that they do every day, become visible. And that's what we're seeing right now. And so even there, I hope we don't return to normal in that respect, because I want the work that public health does to be visible to all of us. But there will be ways in which we do return to normal. When that happens is difficult to know. How that happens is equally difficult. In the same way that we arrived at where we are today by climbing a set of very steep stairs, we will return to normal by reversing that climb back down. It won't happen in one day. It may not even happen in 1 week, but it will be a stepwise process, and it will be guided by our understanding of the data, as well as our understanding of what might happen if we do so too quickly. We have to remember that by removing all of the protective measures that we've put into place too quickly, we could see yet another spike in disease. And so that's why I again would like to thank everybody for abiding the physical distancing requirements that Governor Mills has put into place. But it's also a good opportunity for me to ask for your patience. How we move back to normalcy will take time, and how we think about it will take time. But what I promise and pledge to you is that, one, we will do so with our common humanity in mind. Two, that we will do so using science and data at our core. And three, we will be transparent about the way in which we approach those decisions. So with that, I thank everyone, and I look forward to talking tomorrow. Thank you.